I'm going to give is, as you can see, entitled Multifactorial Limb Swelling in Lipedema. Disclosure standpoint, minimally relevant at best, just because the word lymphedema will be mentioned repeatedly. And so the talk, again, is on hybrid or multifactorial causes of limb swelling that you will often encounter in the setting of lipedema. Now, before we get there, and because as I've already referenced, because as I referenced previously, lymphedema often complicates lipedema, you have to be aware of some of the salient clinical features of lymphedema. And so let's go through those. So what about foot and toe involvement? Here we have two cases, two different patients of rather florid lymphedema. And you can see, despite the florid lymphedema, there is quite disparate amount of swelling within the foot in one of these. So the question is, which one has primary, which one has secondary lymphedema? Again, florid lymphedema, but a big difference in the amount of swelling. Well, as already flashed up here, the one with the pronounced foot swelling is primary lymphedema, and the one with the minimal to no foot swelling is secondary lymphedema. It's important you recognize that pronounced dorsal foot and toe swelling is a primary lymphedema phenotype. That patient obviously has primary lymphedema. You can't even see the toes because that foot is so swollen. Now, another concept that I alluded to, what about the appearance of the toes? Not just swollen toes. So here we have a patient with dysmorphic or just very abnormal shaped toes with very deep skin creases as seen here. And when you see patients with lymphedema, they'll have a little bit of creases in your toes. You may have creases in your toes, but I doubt they look like that. I mean, it looks like somebody took a knife across there. And then also look at the toenails. The toenails are very small, they're hypoplastic, and they're upturned. Sometimes we refer to these as ski jump toenails. Very abnormal appearance. These are all consistent, again, with primary lymphedema. So I suspect you're wondering, well, who cares? Why am I talking about lymphedema? I came to a conference on lipedema. Why should I care? Well, because patients with lipedema and secondary lymphedema, also known as lipolymphedema, typically have minimal to modest amounts of foot and toe swelling as seen here. I mean, you can see a dramatic representation of lipedema in this woman, but just a minimal amount of foot swelling. And that's what you would typically see because it's secondary lymphedema. So that's why it's important. Now, let's say you see a patient, or the clinicians in here, or you as a patient have a foot that looks like this. It's obviously quite swollen. You see the deep skin creases, and you see the hypoplastic toenails. Do you have lipedema? I'd say no, you probably have primary lymphedema, or you could be that rare subset of patients that have both lipedema and primary lymphedema. Very unusual, but I see a lot of lymphedema and lipedema both. But I see a couple of these a year, and they're very hard to tease out. And just so we're all on the same page, it has nothing to do with lipedema, but if you see swollen legs that have this discoloration, this eczema, this scaling, a modest amount of foot swelling, that's consistent with chronic venous insufficiency. Where'd my insufficiency go? That's interesting, I got cut off. It's chronic venous insufficiency, and by definition, all patients that have chronic venous insufficiency, incidentally, also have secondary lymphedema as well. By the time you start swelling in the setting of venous hypertension, that connotes secondary lymphedema. And the reason I show this to you, because it's important we talk about our hybrid causes of lipedema. And a good segue into an ultimate pictorial representation of these hybrid forms of lipedema is provided by soon-to-be published data from the Ohio State University Lymphedema Physical Therapy Center, where we collected data over a 3-year period on 463 patients that had lower extremity lymphedema. 55 of these had lipedema. And of this, that was 12%. And it's interesting that when you looked at what was the #1 cause of lipedema with secondary lymphedema, it was actually lipedema mixed with chronic venous insufficiency. Like we said, all patients with chronic venous insufficiency have associated lymphedema. So we refer to that as phlebo vein lymphedema. So the dominant cause as far as referrals into our center with lipedema and secondary lymphedema was actually lymphedema. Now, I'm in no way suggesting that that's the most common presentation you're going to see of lipedema. I just have not only myself, but we just have a skewed population of complicated patients that get referred in. So there's an obvious referral bias. I mean, you think about it. Who's more likely to be referred in for therapy? Somebody just has a little bit of orthostatic edema, or somebody that has a combination of severe chronic venous insufficiency and secondary lymphedema. And let me go back here. The second most common cause was lipedema with lymphedema, marked by foot swelling, also known as lipolymphedema. And the third most common was your typical lipedema, complicated by orthostatic edema, but without foot swelling, occurring in about 11% of the patients. Now, it's interesting that the current thought process now is that anytime somebody has peripheral edema, there's lymphatic system failure. It may not be lymphedema that you think of with foot swelling and high protein and fibrosis, but it represents a lymphatic failure when you have fluid retention. And there's a smattering of other secondary causes. We'll go through one of these. Just for instance, you can see we have lipedema plus lymphedema. So they had long-standing lipolymphedema. And then they had a non-cancer surgery and developed worsening swelling in one limb. And what do you think the most common cause of surgery provoking secondary lymphedema was? Some of you, in here, knee surgery, knee replacement surgery, arthroplasty. Not a lot written in the literature about it, but most orthopedic surgeons are quite aware of this, and if you've experienced it after a knee replacement, you're obviously aware as well. So here is our typical lipolymphedema patient. We see our ankle cutoff sign, there's our lateral malleolar fat pad sign, and then just a modest amount of foot swelling. Look at the toes, a little bit swollen, but not excessively so. They don't appear dysmorphic. You don't see the exaggerated skin creases. So this is a case of lipedema with secondary lymphedema, also known as lipolymphedema, and this was about a third of the patients, represented about a third of the patients referred in to our clinic for therapy. There's a more dramatic case of stage 3 lipedema. Look at the feet. Despite stage 3 lipedema, this is not working, a very modest amount of foot swelling. And that's our typical patient that has lipolymphedema. Now, what do we have here other than disembodied legs, obviously? That's kind of strange, but you have to trust me on this that the patient has a dramatic truncal lower extremity mismatch. We have our ankle cuff or cutoff sign. You have just a modest amount of foot swelling, but now, hopefully, because of that previous slide I showed you, look at the discoloration. The toes aren't swollen. Look at the discoloration you see within the distal calf. That's consistent with chronic venous insufficiency. That's stasis hyperpigmentation. So this represents lipedema with secondary phlebolymphedema or lipoflebolymphedema. Again, the dominant secondary cause. It was referred in to our lymphedema center. And that was about half the patients. And because this was so common, I want to show you a couple more examples of this. And I just think this is a fascinating case. I mean, here you see the patient has a truncal lower extremity mismatch. You see the marked swelling in the thighs, not so much swelling in the calves. And so, you know, I know we're trying to get away from using phenotypes, but this would be a so-called type 2 phenotype where you have hip to knee distribution of lipedema. But look at that marked discoloration within the calves with no foot swelling. So an interesting constellation of both lipedema that's proximal, complicated by distal phlebolymphedema. And then finally, these last two cases I find very fascinating just based on the shape. So I think already you're probably right away drawn to that stasis hyperpigmentation. You see the skin laxity, symmetrical swelling consistent with lipedema. But I'm throwing you a curveball here because there's this unusual atrophy or tapering of that calf. In fact, it looks like an upside down champagne bottle. And here's an incredibly dramatic example of another patient with stage 3 lipedema, with secondary lymphedema, also has obvious stasis hyperpigmentation. But look at that atrophy, that shrinking, sclerotic, bound down tapering in the distal portions of the calves. The inverted champagne bottle, also known as inverted bowling pin leg, and this represents a disorder called lipodermatosclerosis. And you just break that word down, lipo fat, obviously derm, skin, and sclerosis, hardness. So something else that can complicate the lipedema patient. clearly a multifactorial or hybrid limb swelling in the setting of lipedema. Another dramatic example. I mean, look at this woman's waist. Pretty small. Dramatic truncal lower extremity mismatch. You see the skin laxity consistent with lipedema. You see the marked stasis hyperpigmentation, modest amount of foot swelling. But now there's something else in here that you have to account for. Yes, they have lipoflebo lymphedema, but what if I told you that on the underside of this big mass right here, there are nodules, it becomes infected, it weeps, it's hard. This is referred to as massive localized lymphedema, also known as a pseudotumor or pseudosarcoma. And I'll see this in, it's rare, but I probably see 1 or 2 cases at least per year representing a classic example of a hybrid lipidematous swelling. So now I have a patient, had long-standing, symmetrical, stereotypical swollen legs, skin laxity, consistent with long-standing lipedema. And then she has uterine cancer, and she undergoes bilateral pelvic lymph node dissection. As you recall, this made up 2% of our patients referred in. And so if you're awake and not an incurious person, you would think you'd wonder, well, if they took the nodes out of both sides, why is only the left side swollen or more swollen than the other? I mean, it's dramatically more swollen. And it's 2 reasons, but the predominant reason is because of what's known as the May-Thurner syndrome, and that is your left pelvic vein is chronically compressed by the overlying right pelvic artery as seen here. The red structure compresses at about the level of your navel, by the way. And everybody has the same anatomy, but when you're overweight, you have more compression, and at least initially, this increased pressure within the vein, these increased pressure which leads to increased fluid, can be processed by a lymphatic system that kicks up its output and increases its lymphatic output about 10-fold. But along comes something else that stresses this already stressed lymphatic system, such as taking the lymph nodes out, and then florid lymphedema ensues. And there was one more reason this patient was already stressed and predisposed to developing worsening left-sided swelling. We talked about this earlier. Knee surgery. So, in a very, very interesting case, great example of hybrid swelling. So again, lipedema patients can get unilateral swelling when something is superimposed in the equation. And this is, where's Jerry? Is he still here? Did he leave? Darn, I was going to give him a hard time on this one. Okay, so here's a patient that has had swelling, bilateral leg swelling, since her late teens. And you can see here that there's a lot of swelling in those thighs. Looks like typical lipedema up in the thighs. And in fact, this patient has a dramatic truncal lower extremity mismatch. There's a lot of staining in the calves. Now, most of that is actually due to what we refer to as post-inflammatory, post-infectious hyperpigmentation. So this patient has had recurrent bouts of cellulitis that's really leading to most of that discoloration. What do you see here? Dramatic ankle cuff or cutoff sign, right, that you typically would see with lipedema. You see a lateral malleolar fat pad sign that you typically would see with lipedema. But what's not consistent with lipedema? Dramatic foot swelling. Remember what we learned, when you see significant foot swelling, that typically is found in primary lymphedema, and that this patient has a truncal lower extremity mismatch. So was this patient actually one of these rare patients that has lipedema combined with primary lymphedema? It can happen, it's just rare. Or do they have, as the Europeans refer to, lympholipedema? That is, they have long-standing primary lymphedema that's complicated by secondary lipedema. Not lipedema in the sense that we're all familiar with, but it does represent fat deposition. And these become very, very tough to sort out. And one way I do this is by asking, do they have the characteristic features of lipedema, such as easy bruising? This patient had no easy bruising. Do they have significant pain or cutaneous hypersensitivity? This patient did not have that outside of bouts of cellulitis. So this patient actually had primary lymphedema with secondary lipedema or just excess fat deposition. Very interesting case. I'm just going to digress a little bit here about this secondary fat deposition. Now, back to our discussion on lymphedema. Lymphatic dysfunction, as we see here. So what happens when you have lymphatic dysfunction? Well, you get immune dysfunction, which leads to recurrent infection and cellulitis like that previous patient had. So that was a tip right there that they definitely had lymphedema. You get associated interstitial edema, not surprising. You get progressive fibrosis of the skin and the subcutaneous tissues, but you also get adipose deposition. Continuing our theme that lymphedema provokes fat deposition. There's a schematic here just showing that unabated lymphatic leakage stimulates adipose tissue lipid deposition. And here's an article, or a graph here, bar graph here from a 2005 reference, what I thought was revolutionary because still nobody was aware of this at the time. Now there's beginning to be more of an awareness of this association. And you can see here when you compare L, which is the limb with lymphedema, to N, that is the contralateral or other uninvolved limb, you see a 58% increase in limb volume. Not surprising. However, half of that volume is due to fat deposition. There's a 73% increase in fat deposition in the limb that has lymphedema. And there's obviously a post-mortem specimen just showing you that tremendous fat deposition that complicates lymphedema. Another example of patients of mine that have primary lymphedema complicated by secondary fat deposition. Ankle cutoff sign looks just like a lipedema patient, right? But you got excessive foot swelling. Dramatic example, symmetrically swollen legs. Look at that ankle cuff or cutoff sign. Look at the abundant perimellar fat deposition, yet you have significant dorsal pedal swelling. To make it even more confusing is this fat deposition occurs within the legs, so they are mismatched. As I referenced earlier, they have a truncal lower extremity mismatch. And to make it even more confusing with lipedema is it tends to be diet resistant. I had a patient with primary lymphedema last week. She told me she lost about 120 pounds with her gastric bypass surgery. Legs didn't change much at all. All of her weight loss was up on top. So in conclusion on our first lecture, probably the most common hybrid that's out there, even though it wasn't in our series, would be just typical lipolymphedema. There's a stage 3 with just a modest amount of foot swelling. In our series, remember the lymphedema patient. And then finally, as far as hybrid limb swelling, again, it just becomes confusing when you have two subsets of patients that both can have a dramatic truncal lower extremity mismatch as seen here, yet one has obvious lipedema on the left of the screen, but on the right side, that's primary lymphedema. And look at the size of his arms compared to his legs. That's a dramatic truncal lower extremity mismatch. And again, it's diet resistant. This poor guy, he ultimately passed away, but and I used to see him, and he refused what could have been a curative surgery, and he'd always tell you, everybody tell him to lose weight, and he would, but he would just shrink up here. The legs never changed. He spent the last 6 months of his life in bed, lost probably 100 pounds, his legs never changed. And so obviously there is a link between these disorders, and on some level it's got to involve the lymphatic system. Obviously there's a difference in the foot swelling, but there's a link between the two.